Thanks, Charles. So next, I'm pleased to introduce our next speaker, Professor Darya Rudym, who's a lung transplant pulmonologist at NYU Langone.
Thank you so much, Eamon. Thank you for inviting me and for the introduction. So what I hope to walk you through over the next session is our experience here at New York University in establishing a home monitoring program way before COVID and how that evolved for our lung transplant recipients as we saw our program and COVID take over the last few months. So to give you a little bit of background, the number of lung transplants in New York has increased over the last few years. So prior to 2017, there was really just one lung transplant program in New York City. And over the last few years, two others have established themselves, ourselves pictured here in purple, and then another center in light gray, and then the pre-existing program, which is New York Presbyterian Columbia in dark gray. So we're a fairly young program on the map of New York City. And from the get-go, we really envisioned that we would like to have some sort of home monitoring in place for all of our transplant recipients. Why? Well, it was really for the benefit of having both increased patient and provider assurance. What I'll say there is that actually came from the other program in the city from NYP in Columbia, where we didn't have as much of a robust home monitoring. And as a provider now in my institution, NYU, it offers me a lot of comfort to know that patients, when they go home after having received a lung transplant, have a set number of parameters that are being monitored on a daily basis and remotely. So it just offers a lot more reassurance that the patients are doing okay. And for the most part, our patients tend to agree that they see a lot of benefit in having home monitoring in place as well. Our second major advantage of starting home monitoring for patients was really just to expand the geographic pool. So all three of these programs that you're seeing here in New York are New York City centered, and New York State is a really large state. There are many neighboring states as well, and a lot of patients who do need transplants. So what this allowed us to do is to expand our potential candidates to all the way upstate New York, north of Albany. So these are folks who are 4 or 5 hours away from New York City, and we were able to offer them this intervention, knowing that we would have a robust monitoring in place after they receive a transplant, so that appropriate routine care is being provided for these folks who are farther away geographically. So what does it actually look like for our patients? So on that index hospitalization, the hospitalization during which a patient receives a lung transplant, upon discharge, we sit down with them and we equip them with the following devices. So there are a number of different things that essentially look at their vitals. So we're looking at their blood pressures, heart rates. They do get a thermometer. Obviously, lung transplant recipients are immunosuppressed, so they're very much at an increased risk for infection. So temperature is one of the vital things that we'll be checking for them. They do get a pulse oximeter. They get a scale and glucometer, and actually a pedometer as well. Those things are crucial as a lot of these folks go home on higher doses of steroids. They end up gaining weight. Their glucose is not well controlled. So those things we monitor very closely as well. And then my kind of absolute favorite and really the holy grail of the whole thing is the clinical grace parameter. So for those of us who don't do lung transplant on a daily basis, one of the most common and most feared complications of lung transplant is rejection. And it happens to a lot of folks. It happens to the majority of folks, and most of the time it is asymptomatic. So the only ways to pick up a rejection in a lung transplant recipient is either to do a bronchoscopy with a biopsy or to see an FEV1 decline. Now imagine if you have a patient who is seen, say, every 2 months, and in the 2 months in between that they're not being seen by a provider, they could be having an FEV1 decline that we otherwise would not know about. So having this handheld spirometer in place with which they go home, at least for us, has been an incredible amount of reassurance and comfort knowing that we are on daily basis monitoring the FEV1. All of this gets linked through Bluetooth or cellular data to a healthcare app, and then gets auto-populated into our electronic medical record. So we use Epic as our electronic medical record, and this is what my screen would look like if I were to log in and review a patient. So on the left side, you see just a day kind of screenshot of what that person's values are like for that day, their blood pressure, steps, heart rate, oxygen saturation, temperature, and FEV1. I would say that on the vital signs alone, we have picked up a number of different things. So there are definitely a few blood pressures that were a little bit on the lower side that we were able to pick up and intervene upon, and actually a fair amount of heart rates that we thought were a little overly beta blocked, or we actually picked up a case of myxedema in somebody who had a really low heart rate at home who was completely asymptomatic, turned out to be a drug-drug interaction from transplant meds. But my favorite attribute of this home monitoring is this. So this is what the FEV1 looks like for any of our patients when they do home monitoring on a daily basis. So this is a trend that you can see here on the top over the 6 or rather 8 months of a person's transplant life. So you can see that after transplantation, they had an FEV1 in mid or low to mid 4s, and as the time has gone on, the FEV1 decreased. So this is rejection. If you look particularly between November and December, so over a course of months, from 1 month, from November 2nd until December 8th, there's rather precipitous decline in FEV1. If we did not have this person on our radar, or if we did not have home monitoring in place, we would just have no idea. A lot of the times, folks don't feel this type of FEV1 decline. Some do, but not all. So this was really instrumental in helping us detect rejection, early rejection in a lot of these folks. This particular person was brought in, they underwent bronchoscopy with biopsy, were able to diagnose rejection and intervene with steroids. So the benefit was definitely there way before COVID, and everything I'm saying right now was really all before COVID. So we were very, very fortunate to implement a system really where we started to do home monitoring along with some video visits before any of this unraveled. So pre-COVID, we did about 3 to 7 video visits per week, and these visits were mostly for the folks who live farther away, so in Albany or far in Long Island. We do actually have a few patients who live in Carolinas. There's one patient that lives in Florida, so folks have really traveled a little bit farther away, and we were able to monitor them appropriately with video visits and home monitoring. We looked into this in the very beginning, and one thing I haven't mentioned yet is in general, and this is center-to-center dependent, the typical follow-up for a lung transplant recipient is a weekly clinic visit for the first 3 months. That's obviously very time-consuming. It's costly. Driving into New York City, you're paying for gas, you're searching for parking. There's a lot of different variables in there. So to take that away and have a essentially remote monitoring where we're seeing somebody by video offered a lot of comfort to a lot of people. So I started doing that for folks who live far away. And we looked into this rather early and saw in about 2/3 reduction in our outpatient visits. So we were able to minimize the amount of physical face-to-face interaction, but still provide adequate care. This was, of course, because the home monitoring was done on daily basis by the patients, and our review of the home monitoring was done on a weekly basis. Patients were then called if we detected anything. We do set certain parameters, kind of alarms of values that fall outside of what we expect to be the norm. And of course, we intervened early on anything that popped up as abnormal. So all of this was before COVID-19. And so when COVID hit, and COVID hit hard, as Dr. Powell had already mentioned in his presentation, we were incredibly lucky to have had this system in place for our transplant recipients. Basically, on March 23rd, as it was really the first week that things were being felt very heavily in New York City, we were able to convert all of our patients to telemedicine in conjunction with home monitoring. So not a single person was seen in person unless they had to be admitted or undergo a procedure for 2.5 months. We asked our patients to do home monitoring twice daily. We were, of course, concerned about the well-being of our patients and what COVID would mean for a lung transplant recipient. And over the course of the last 2.5 months, we have done well over 250 virtual visits and twice daily home monitoring with our devices. So what has panned out of that is we've been able to maintain routine transplant care despite being on quarantine and lockdown and social distance with a lot of restrictions that we previously have never had exposure to. And the additional benefit, which we're very glad about, we were able to pick up two asymptomatic cases of COVID-19 in our transplant recipients, and we picked them up early because we had the home monitoring, had them take temperatures at home and call in. And so both of those folks got appropriate care, early care, and made it out very well. So all in all, having had this system in place was just something that we were incredibly lucky to have. So now moving forward, what we have seen over the last week and a half, we have opened our physical clinic on really kind of case-by-case basis to determine who would need to come in. And this is mostly just physical exam folks who really want to make sure we're seen in person. But over 90% of our visits remain virtual visits, and we continue twice a day home monitoring. And so far, it's working very, very well. So we intend to proceed this way for probably very, very long time. The first wave of COVID seems to be at its tail end, but nobody really knows what's going to happen and how much further this will take us and the rest of the country, so in the world. So we're really hoping to continue this kind of practice. And again, we had no idea that this was coming, and we're so lucky to have had a telehealth and a home monitoring system well oiled before COVID had hit. And so we're learning, and we'll hopefully continue to learn and experience through all of this. And we wish for everyone to have some sort of systems in place when disasters strike, and hopefully we'll make it out okay on the other side.